What is cervical myelopathy? Cervical myelopathy is the common form of neurologic impairment that occurs due to compression of the cervical spinal cord at the cervical spinal level. It most commonly occurs due to the degenerative cervical spondylosis. Through this picture, we can see that there is a compression of the spinal cord that happens at the cervical spinal level. It can happen between C1 to C7. Incidence and prevalence. Cervical myelopathy is most commonly occurring in elderly aged from 55 years old and above, and it equally affects both male and females. Cervical myelopathy is most common in Asia, where Asians are at increased risk of cervical myelopathy. Given statistic is 1.9% to 4.3% of individuals older than 30 years, due to their increased prevalence of ossification of the posterior longitudinal ligament, OPLL, which is a source of compression. The etiology of cervical myelopathy. It can be caused by osteoarthritis, congenital stenosis, tumor, trauma, cervical kyphosis, and OPLL, which is ossification posterior longitudinal ligament, which is an idiopathic cervical spine anomaly. Clinical features of cervical myelopathy: tingling or pain in fingers, pain or stiffness in the neck, trouble in walking, unable to perform delicate motion, loss of balance, and problem with bowel and bladder control.
How to diagnose cervical myelopathy? The earlier cervical myelopathy is diagnosed, the more successful the treatment is expected to be. However, cervical myelopathy symptoms are not unique to this condition and are often mistaken for normal signs of aging. To diagnose cervical myelopathy, we can use first provocative test, which consists of Clonus sign, Hoffman signs, and Babinski reflex. The first test is Clonus sign. The patient has to dangle their legs off an exam table or chair. Then doctor quickly dorsiflex the foot. If the foot begins to spasm or beat up and down several times, the Clonus test is considered positive. Next is Hoffman sign, which the test is done by tapping or flicking the nail of the middle or ring finger to produce flexion of the index finger to the thumb. The last test is Babinski reflex, which done by running the pointed object from the heel along the lateral aspect of the foot, and is considered positive when patient produces extension of the big toe and abduction of the other toes. The other way to detect cervical myelopathy, doctor also will conduct an MRI scan, which is the initial test for patient with suspected cervical myelopathy. High signal changes seen in the spinal cord with T2 weighted imaging can indicate permanent spinal cord damage or myelomalacia. MRI also has demonstrated high level of sensitivity and specificity. Pathophysiology of cervical myelopathy largely involves compressive force on the spine due to combination of first, static factor, which result in acquired or developmental stenosis of the cervical canal. Next is dynamic factor, which involve repetitive injury to the cervical cord and causing dynamic pressure on the cord when flexing and extending. The last pathophysiology is vascular aspect of the spinal cord, which is ischemia as a major underlying pathologic event contributing to myelopathy. Oligodendrocytes respond poorly to ischemia, and this may explain the demyelination that occurs with chronic cervical myelopathy. This is the difference between normal cervical vertebra and spinal cord and cervical vertebra with canal stenosis and cord compression. So, there are a few management strategies that can be given to the cervical myelopathy patient that can be divided into conservative and surgical. The aim of management are to decreasing pain by reducing spinal cord and nerve root inflammation, as well as improving the patient function and ability to perform daily activities. First, for conservative treatment, doctor can prescribe anti-inflammatory medication such as ibuprofen and naproxen. This type of medication may have some short-term benefit in relief of painful symptoms. The other conservative treatment can be used is temporary immobilization of the neck. This type of treatment may have some benefit in temporary relief from moderate neck pain, for example, using of soft cervical collar. For surgical treatment, patients with overt spinal cord compression resulting in spinal cord dysfunction may be referred directly for consideration of surgery. Aim of the surgery for cervical myelopathy is decompression of the spinal cord. There are two common indications for having surgery, including first, symptom failing to improve after 4 to 6 weeks of non-surgical treatment, and progression of the symptoms in spite of non-surgical treatment. As an occupational therapy, we contribute in this condition straight away after the surgery. First, we assess the patient motor function and performing ability in ADL IADL, work or leisure. And then, we identify what is the most valued occupation that patient want to improve. For example, restoring patient hand dexterity to button shirt and holding a cup. Next, we also can educate patient with good neck posture.
Prognosis of this condition. It tends to be progressive and get worse, but prognosis for recovery is better in patients with early surgery.
There are few impairment and functional limitations that will be experienced by the patient. As for impairment experience, patient will have decreased range of motion in cervical spine, and patient will also experience numbness or paresthesia in one or both hands, and as the disease progresses, one may experience shooting pain at neck and arm area and travel down to the spine. Person with cervical myelopathy will also experience some functional limitations such as weakness of grip strength, for example, unable to hold pen. Next is difficulty to perform fine motor skills such as buttoning shirt and brushing teeth. Then, patient will also have difficulty in mobility and balancing, and they also will have limitation in self-care activities such as combing hair and caring for nails.